rescind also. Just know that you can rescind. Okay, so a DNR, DNI, and MOLST. These are all acronyms, because everything in healthcare is an acronym. A DNR is a do not resuscitate. A DNI is a do not intubate. And MOLST is an acronym for Medical Orders for Life-Sustaining Treatment. So again, all of these support what the patient wants. Okay, so I just gave you that example before. Do not resuscitate, in other words, do not give me chest compressions, do not give me any medications. If I go, leave me be, let me go naturally. Do not intubate, which means do not put a tube down my throat and connect me to a ventilator and the machine is breathing for me. If I'm not breathing, let me go. And MOLST is what the physician or the provider is going to order for any, if there are any life-sustaining treatments. So say, for example, I don't know, I don't want to be resuscitated or intubated, but I do want to be fed, or I do want to receive fluids. You could say that. Or you could say you want none of that. It's totally up to you. The patient does not have to be on hospice to have a DNR in place. So in other words, I can have a DNR right now if I want one. Right? I can put that in my advanced directives. You do not have to be terminal. Hospice means terminal. Okay, less than 6 months to live in order to have a DNR. So there are people that just want to have the bare bones basic. There are people that want nothing. And then there are people that want everything. But remember I told you, what's the benefit of having any type of advanced directive? What's the benefit? Do you remember? Well, there's actually two benefits. Yes.
There's no ambiguity.
Exactly. Exactly. What you want is what you want. Okay, so you will get what you want. And the other advantage to having a set of advanced directives is, you know, within your family, I don't care if there's 2 people in your family or there's 2,000 people in your family. Somebody's going to want one thing, somebody's going to want the other thing. And there's always going to be some kind of conflict, okay? I've been witness to many, many instances where I knew as a medical profession there was no way this individual was going to survive whatever it was. But the family wants everything done. Some of them don't want everything. Patient's 99 years old, they live their life, let them go. No, we have to do this, we have to do this, we have to do this. You're always going to have that conflict. You have any set of advanced directives, just that off the table. So they can be happy or not happy with your decision, but it's still your decision. And your decision will be honored. So that's something that, you know, is a good thing. Okay. Death and dying, yeah, we have this in nursing too. We talk a little bit about this in every course. Anybody here of Kubler-Ross? Elizabeth Kubler-Ross? What did she do? She did all the different stages of dying, yes. She identified different stages of dying, which you don't have to memorize. But obviously, we all got to get here at some point. And it's relative. You know, the death can be an actual physical death, or it could be the death of my childhood. You know, I'm never going to go back there again. I'm never going to be a child again. You know, I'll always be an adult. So you're either taking it literally or you're taking it conceptually. Okay, but it's still there. All right. So just know that. Grief. We all have been through grief. Okay, it's emotional. It is a result of some actual or perceived loss. And a loss could be a final loss, it could be a temporary loss, it could be a separation, and it involves all of our different emotions. So say, for example, you could be grieving because you lost someone near or dear to you, they passed away. Or it could be you're grieving because
Divorce?
a divorce, absolutely, a change, nobody likes change, we all know that. It could be, I'm grieving because I had a mastectomy, I had breast cancer, okay, so body image, so there's all different layers of it. In this country, I don't think we pay enough attention to death and dying. Some cultures have very, more embracing perceptions about the process, you know, because think about going through the process and the grieving and what follows after and the support. You can get a lot of closure from that, as opposed to just not talking about it or not acknowledging it. That's tough too. So this is her book, Elizabeth Kubler-Ross. I don't know when she wrote it, but it's been quite some time. And she did groundbreaking studies on her theory related to everything that we go through when it comes to any type of loss. So you'll hear a little bit about this in each course, but basically the first stage is denial. No, not me. No, I didn't get a cancer diagnosis. No, my physician is wrong. No, that's not me. And you feel very isolated. After a while, you become very angry.
Why me?
Yeah, the why me thing, and you get very angry, and many of us as nurses have taken care of patients in this anger stage where they really vent anger upon you because you're standing right in front of them. So you have to try and learn not to take it personally, and sometimes if the patient is particularly difficult, they will rotate that patient among the nurses on the floor, so not one person is constantly with that individual. It's kind of like a shared experience. After the anger passes, if they can get past that, it's the bargaining stage. Well, what if I do this, and maybe this won't happen, or they bargain with their faith, they bargain with their physician, they bargain with themselves, but it's all about, well, I'll change and this will occur and I'll get better.
I will never smoke again if I
Yes,
get better.
I'll put that cigarette away for good. Yeah, and then they get depressed. This is a place where I have found that patients tend to get the most stuck, is in that depression stage. So they need a lot of support during the depression stage because it's a dark place. You really don't want people spending a lot of time there. And then if they can find their way out of that, then it's usually acceptance. They become more relaxed. They know what's going to happen, so now they can put their affairs in order, or make peace with whomever they need to make peace with, or if it's something like a mastectomy, okay, so I accept I'm going to have an artificial breast. That's okay. I dealt with it. It's good. I'm still alive and breathing. I can move on. So everybody goes through things at their own rate. We as nurses, we just recognize it, we identify it, and we get the appropriate team members to give them the support that they need while they are going through the stages. Okay. Physical death. Physical death for us is the cessation of any type of respirations and circulation, right? The body starts to shut down. Okay, so some things that we would observe if we were taking care of someone that was actively dying, that is the new term that they have now. They're actively dying. They're starting to go through the process where their body processes are shutting down. More than likely, they won't be alert. They will no longer be able to swallow. They will have some pitting edema. What is pitting edema? Pitting edema is when you press on an area of their skin
Oh my
and it
God.
leaves like an indentation. Okay? Because they're swollen, they have a lot of fluids. So they have pitting edema. Decreased GI and urinary tract activity, so everything is slowing down. So it's not gonna work anymore. They may be incontinent, as they lose final muscle, contractions, and they might be incontinent of urine and bowel. They may appear cyanotic. What does that word mean?
The blue.
Yes, so they look blue. Okay, their nail beds, instead of being
Around the mouth.
blue around the mouth, right, circummoral cyanosis. Usually their body temperature will elevate and then it will drop, which just means that the hypothalamus is not working and you can't regulate your internal body temperature. Your blood pressure is gonna start decreasing, your heart rate is gonna start decreasing, okay. And your respirations are gonna be very irregular. So you might see the respiration start dropping. You know, maybe they were 16, and then they were 12, and then they were 10, and then they were 8. And then there might be long pauses in between breathing. They call that Cheyne-Stokes breathing, where you take a breath, and then you don't breathe for a really long time, like a couple of minutes, and then you take a breath. Again, those are kind of like the agonal breathing, or Cheyne-Stokes breathing. And then when you do not have any more vital signs and there is no blood pressure, or you take their EKG and it is completely flat, then the provider will pronounce the patient. Okay, we don't pronounce the patient. We know, but we don't pronounce. So it's not within our legal scope. So the provider will pronounce the patient. And they will give a time so that it can be put on the death certificate. Yes, question?
The rapid shallow breathing, is that the same like the diaphragm?
Yeah. Yeah, that's like the regular everyday term, but we call it agonal breathing or Cheyne-Stokes breathing.
Okay.
And the last slide here is the nurse as delegator. So we as nurses, we can't do every single thing, can we?
No.
During the course of the day?
No.
No, why? Because we have too many things to do, right?
Patients and.
So, can we delegate some of our tasks?
Yes.
We can. So tell me, who do we normally delegate to? If I say, I need a set of vital signs, can I say,
PCT?
Doc, can you go in there and get me a set of vital signs? No. We don't delegate up, we delegate
Down.
equal or down. So, can I ask a colleague, another nurse?
Yeah.
Yes, if he or she is not busy, they might do me that favor. But more often than not, I would delegate down. So I would delegate to who?
The
Vocational
PCT.
nurse?
P-
The vocational nurse, yes, the LPN or
P-
the
PCT.
the CNA,
CNA.
nurses aide, UAP, unlicensed assistive personnel, we would delegate to them. Okay. And what would I do? What would I do? I would have to let them know what I want done, right? So that's what I mean by defining the task. Can you take a set of vital signs for me in Mr. Jones in 502 bed A, right? I have to be specific. I have to be specific. I can't say, I forget his name, but down the hall around the corner.
He's wearing.
He has a beard. He might be in the bathroom, but he might be sitting in the chair. I don't know, just go in that direction, you'll figure it out.
We'll find him.
You can't do that, right? Is that, professional delegation? No. Is that even good communication? Oh, God, no. Okay, so I have to be able to define the task, and then I have to make sure I'm giving it or delegating it to the person that it's within their legal scope of practice, right? So can a UAP do the set of vital signs? Can the nurses aid do vital signs for me?
Yes.
Of course they
Yes.
can. Absolutely, absolutely. And the key thing to remember is any time you delegate something to someone, you are still responsible for the outcome.
Yeah.
So if I say to the LPN, can you please give Mr. Jones in 502A a soap suds enema? And they say, okay. And then I never check, but I give report and I say that there was a soap suds enema given, and the next nurse goes in and finds out that it wasn't given. I'm still responsible.
And
So
the
I
nurses are
need-
responsible?
Yes, but I'm above that person in hierarchy. So I am responsible to make sure that it is carried out. So that's what we mean by following up, to make sure that it was done, okay? Because some people will yes you to death, and they won't do anything. And then and if you don't follow up, then you find out towards the end of your shift, oh my God, this patient's blood pressure was never taken all day, or oh my goodness, this patient wasn't washed and the family is coming up in the elevator, and what am I gonna do? So that kind of speaks to good interpersonal relationships with your team members. You know, you can't just dump on somebody. If they're the only nurse's aide on the floor for 50 patients, you cannot give them all your work to do. It's just not fair, and it's not right, and you're not gonna do it. So make sure you know who can do it, make sure you divvy it up, okay, so that everybody has enough work and somebody is not overloaded. Then you need to follow up to make
Make sure it's
sure that it's done, okay? If there's any questions about anything, can this person come to you?
Yes.
Of course they can come to you. So you as the nurse need to know what their scope of practice is,